Hey, Dr. Ali, how are you? I was just about to call you.
Oh, really? Yeah, that's one. I just came to see a patient, Ward 7, who asked for oncology opinion.
Well, I was about to call you for a patient in Ward 3.
Okay.
Actually, this patient just presented to us with right upper quadrant abdominal pain. And she's about 40-year-old, and we did ultrasound, we just found the liver lesion.
Oh, just one liver lesion,
Yeah,
yeah?
just a single liver lesion.
Okay, and have you done anything else for him?
No, not yet.
Okay. PET-CT scan may contribute to the management of patients with cervical adenopathies from a cup and those with a single cup metastases. For other cups, the role of PET-CT scan is limited, making this imaging procedure not mandatory in the initial systematic workup. For a liver lesion, it is important to rule out primary liver malignancy as well as metastases from other sites such as GI or breast, particularly in females. Thorough physical examination, including head and neck, rectal, pelvic and breast examinations, basic blood and biochemical analysis, and CT scans of thorax, abdomen and pelvis constitute a minimal basic workup.
Patient we discussed her about 2 weeks ago, and now we have actually the result of the CT, and hopefully the result of the pathology is out. The CT scan actually showed a 5 centimeter lesion localized in segment 4 of the liver, and there were few retroperitoneal lymph nodes but no other obvious pathology. Can we have the result of the pathology, please?
Oh yes, thanks. I think I remember this patient from previous discussion. And now we do have the results of the CT-guided liver biopsy. And it does confirm indeed an adenocarcinoma, poorly differentiated. Immunohistochemistry so far showed CK7 positive and CK20 negative. I'll have more immunohistochemistry to follow and feed up to you. CK7 positive and 20 negative immunohistochemistry pattern is seen in breast, lung, mesothelioma, ovarian serous, uterine adenocarcinoma, salivary gland, thyroid, and pancreatic cancers. Colorectal adenocarcinoma is usually CK7 negative and 20 positive. So although a colonoscopy might be indicated, in this case it is not considered a priority and can be considered if the other tests fail to reveal a primary site. Right, Dr. Ali.
Yep.
You are seeing a 45-year-old lady in the oncology clinic with a month history of weight loss and abdominal pain, non-smoker, and no other significant past medical history. Chest X-ray showed right pleural thickening. CT scan showed right pleural thickening and multiple peritoneal masses with disseminated enlarged lymph nodes in the abdomen and chest. What would you do?
Well, I will order for a biopsy, and I will send for tumor markers.
Great. So you did a biopsy, and next week the histopathologist sent you this slide. Come on. You think this could still be a lung cancer despite of the negative TTF1?
Possible, because there is a small proportion of lung cancer patients that still have a negative TTF1.
Well, fair enough. Next day, the pathologist rang you up to update you on the immunohistochemistry. Now, the specimen shows the follows: CEA negative, PAX8 negative, ER negative, HER2 negative, CA125 negative, while Wilms tumor gene 1 and claritinin both are positive. Do you still think this is a lung cancer, or are you going to change your mind now? CK7 positive and 20 negative is possibly to be a lung primary. Lung adenocarcinomas are TTF1 positive, expressed in over 70% of the cases, and is an important stain in carcinoma primary. Other CK7 positive and 20 negative tumors are breast, mesothelioma, ovarian serous, uterine adenocarcinoma, salivary gland, thyroid, and pancreatic cancers. Peritoneal mesothelioma is an uncommon malignancy. Often, Wilms tumor 1 and claritinin are positive in mesotheliomas and are suggestive of the diagnosis. This is a highly aggressive tumor that occurs most often in the pleura and peritoneum. Ovarian serous carcinoma is another possibility. However, these tumors will normally express PAX8 and WT1.
Well, we have Mrs. Maria. She was referred for 2 lumps in her growing bilaterally, and the examination was consistent with bilateral lymphadenopathy. And we did for her a CT staging that did not show the disease elsewhere, and we also did a biopsy. Of note, her tumor markers are all within normal. Can we review the histopathology, please?
Sure, yes. So, indeed, we received the specimen from the inguinal node biopsy, and it does confirm a poorly differentiated adenocarcinoma, but this is of no obvious significance. So, as stands, it's a carcinoma of unknown primary.
For localized adenocarcinoma in the inguinal nodes, a thorough examination is needed to establish a primary. Given that the bilateral inguinal lymph nodes are the only site of disease, local therapy with more surgery should be offered. Adjuvant radiotherapy plus minus chemotherapy could be considered if clinically indicated. However, it's also important to weigh the benefit of adjuvant therapy with the potential risks of lymphedema, particularly if radiotherapy is given.
We hope you liked our video. This is Acting for Clinical Education.
And don't forget to check the reference down below.
Please like, share and subscribe, and don't forget to join us every Thursday 5 p.m. Greenwich time.